MMPI-2 is a broadband test, a psychometric test of personality and psychopathology. MMPI stands for Minnesota Multiphasic Personality Inventory. Now, this test was developed in the 1930s and 40s at the University of Minnesota uh, by interviewing and developing norms based on the inpatient and outpatient population at the psychiatric facility at the university, and later was revised to the MMPI-2 in the 1980s by the same team at the University of Minnesota. Now, when we talk about a broadband personality test or a broadband test of psychopathology, so it basically measures the entire spectrum of personality variables, psychopathological distress, and overall functioning and levels of functioning ranging from low to average. Average would mean a general level of psychological adjustment, and leaning more towards higher and very high scores, which would signify some kind of lack of adjustment or some psychopathological inclinations. Now, talking about administration of the test, these are the basic test materials. This is the soft cover test booklet, which has all the 567 items which the test taker has to score on this answer sheet. Now, in the front, you can see where in this area is where the client or the participant would mention their name, birth date, age, and the date of the test. On the inside, now this would be where the person or the client would be answering their responses on the various items. Now, answer responses are bipolar. So, the responses are bipolar, true and false responses, only two options that the person has, and it's a rather straightforward questionnaire. I mean, even if we look at the items that are there, those are all single line, very generic statements which have been keyed and developed specifically to measure different types of scales on the MMPI, which are divided further and which we'll talk about in a little bit of time. Now, before conducting the test, what is very important is for one to have complete familiarity with the entire item set in the test, because it can be interpreted in a variety of ways depending on the kind of population one is dealing with. So, it's important to get everything in context so that if there is a doubt or if the person is not sure what the question means, then that clarity can be given. Now, administering the test. Administration is fairly simple. Responses are either true or false. Now, the client has either the option of responding true or responding false. Now, in a scenario where they are not sure of what the response could be, it's sometimes true, sometimes false, they are ambivalent about the response, they can mark both. Alternatively, they can leave the question if they're not sure what the response could be. The idea for the test taker is to urge the participant to answer all questions as far as possible. Well, there are few implications to many questions not being answered. Now, anywhere above 10 questions which are not answered, we are looking at many scales which will lose their value in terms of interpretability, wherein it can render the profile invalid. So, to gain maximum insight into what the test is essentially saying or reflecting about the about the individual's personality and psychopathology, we need maximum responses possible for all the scales. Now, the test environment has to be conducive. The person who is going to be giving the test, one has to make sure that they're they're at as far as baseline as possible, not extremely tired, not fatigued, not under the influence of any prescription or otherwise substance, wherein they are cognitively in the present and are fairly committed to respond to all the items on the test honestly. Now, it's a fairly long instrument, takes anywhere between 60 to 90 minutes to around 2.5 hours as well to conduct. There is no time limit as such to conduct the test, so the person is more than welcome to take breaks and then move forward in responding different items of the test. Now, once the response is given, all the responses are done in how much ever time it takes. This sheet is going to look very different. Now, we're not going to conduct the entire test because that's going to take around 2 to 3 hours. But what we'll see is a pattern of dots which are completely colored in all of these different response areas. Now, when we go through the response sheet after the person is done conducting the test, we'll take a colored pencil. By the way, all responses have to be marked in pencil, because if in case post the test there are some adjustments or some changes that have to be made, so one can erase and definitely mark the other option. That is a possibility while the person is giving the test, and even after the test, if there are many responses where they have marked both, or if one or the other items have been omitted, the test taker, the administrator of the test, can sit with the client, discuss on each of those items and explain it further, clarify the question to them to make sure they have understood what the question signifies and on which direction they lean, and see if we can come to a polar response. If we can, then we mark that. If not, we leave it as it is. Now, all those questions where it's either marked both or have been left have to be struck by a colored line, because they will no longer be a part of the scoring. So, those items we will strike off in a straight line. Okay. Now, scoring the test. So, how scoring is done? I will give you a small demonstration of manual scoring. And later I will explain what those different scales mean. Now, for example, the first clinical scale in the MMPI-2 is hypochondriasis. Now, to measure hypochondriasis, this is what the stencil will look like. And we're going to take this stencil, and you notice these black dots on the top and bottom. Now, these black dots on the top and bottom, and the same black dots on the answer sheet which we see over here, we will take the stencil, go inside these two black dashes, and on all these empty squares that we see, whichever ones we find colored on various items, we will note down the number of items that we found colored and exclude all those where they have been struck off. Now, what that number signifies is the raw score that we have developed. But it doesn't end there. So the raw score will have to be converted into a t-score, which then enables us to interpret it. Now, to convert it into a t-score, it's a very simple formula that one can use. One can obviously, with the test material, you get this book. This is the manual for interpretation and scoring, which has the t-score charts and sheets which we can use to calculate what the t-score for a given raw score is, or we can simply use a formula which is t-score is equal to raw score minus scale mean into 10 upon the scale standard deviation plus 50. Now, which is essentially raw score is the raw score that say we have calculated. Let's say the raw score is 7. The scale mean, which is given in the manual for each and every one of the clinical scales and further subscales and content scales and supplementary scales, which we'll talk about. All of those scale means for males and for females have been given. Scale standard deviations for all the scales have been given for separately for males and females based on the normative data from the MMPI, and based on that we use the formula and we calculate the t-score. Now, there is one thing that we have to keep in mind when calculating, when scoring the clinical scales, which constitute hypochondriasis, that's the first scale. Then we have the second scale is depression, third is hysteria, fourth is the psychopathic deviate, fifth is the masculinity femininity scale, sixth is paranoia, seventh psychasthenia, eighth schizophrenia, ninth is hypomania, and scale 0, which is the social introversion clinical scale. Now, in the validity scales, which basically determine what is the level of interpretability of a certain profile. So we can measure whether the person has been defensive, whether the person has marked randomly using various validity scales. So one measure of defensiveness is the K correction. Now, the K correction, why is it more interesting than the other validity scales, is because it is a measure of defensiveness that the person exhibits while giving the test and responding to the different questions, but it also provides a mechanism to correct for that defensiveness for scales of hypochondriasis, psychopathic deviate, psychasthenia, schizophrenia, and hypomania, where we can add different percentages allocated to these clinical scales of the K raw score and add it to the raw score of those respective scales. That becomes the K corrected score. Now, that will function now as the raw score of that scale, and further we can calculate the T scores. Now, let's talk a bit more about the different scales that we are dealing with. So, first of all, the validity indicators, of which the K correction scale that we were talking about right now. So, the first validity indicator is the question mark or cannot say scale. The cannot say scale basically measures how many items have been omitted from the test, and it is a measure of how many scales or the percentage of items in different scales have been omitted, depending on which we can decide whether that specific scale can be interpreted or cannot be interpreted, or if it has reached a number, let's say beyond 30, then it will put the entire profile into question whether this the test has to be conducted all over again. Another validity indicator is the variable response inconsistency, and the true response inconsistency. Now, the variable and true response inconsistency measures, they measure a tendency to respond in ways that are inconsistent or contradictory. So, these scales are linked in pairs in items. So, let's say a pair of items is marked true on one and true on other. So, if the subject marks the same, it would signify inconsistency. Now, this would basically show if the person is more random or more inconsistent in their responses and can basically put a shadow of level of interpretability of different scales or of the profile itself. And these scales have to be within a range for them to be interpreted, for the profile to be interpreted. Now, the F scale, which is the infrequency scale, this specifically measures random responding. Now, let's say the F scale is higher, is on the higher end, where it deems that the profile is uninterpretable. We cannot directly subscribe to that idea, but for what we have to check is the variable and true response inconsistencies. And if those two measures are within normal limits, then the high score on F would actually signify severe psychopathology rather than a measure of infrequent or random responding. Similarly, there is the next validity indicator is the FB or back F. Now, this measures infrequency in the latter part of the test, which basically shows whether the attitude of the respondent has changed, or of the attitude of the respondent towards the test has changed over the course of giving the test. So, it generally measures post 300 to 370 item band, and post that it will measure whether there is more infrequency. Then the FP scale or the infrequency psychopathology validity indicator, these scores assist in differentiating elevations on F that are a product of genuine psychopathology or are resulting from over-reporting. So, it helps us make that distinction. Now, the defensiveness scales, which is the lie, K correction and S, which is a measure of defensiveness similar to K and L. Now, the lie scale, it reflects defensiveness and deceit while giving the test, wherein the person is not actually showing what they are feeling or what they feel about a certain item or a certain question that has been asked. Now, this does not necessarily signify a general tendency to lie, but it is more indicative of a denial of faults and shortcomings and basically faking good, which is a terminology extensively used in the context of this test. Similarly, K correction, which we spoke of earlier, is also measures the levels of defensiveness and gives a correcting mechanism to this response style on the various clinical scales. Now, now the superlative self-presentation scale, the S scale, it is a measure of defensiveness and a portrayal of self as to be good, wherein the person wants to portray themselves as someone who is an extremely positive person, which could be inconsistent with other responses. An overt presentation, which would veer away from a natural personality presentation. This we can measure through S. Now, the difference between S and K would be where now the K correction scale focuses mostly on the initial parts of the test, where S has items all over the test, which is a more definitive view of if the person is faking good or presenting themselves in a much more positive light than actually. Now, we'll briefly go over different MMPI 2 scales. Now, it is divided into 5 broad categories. The validity indicators, which are most important and the most tricky to interpret. They decide whether the profile, what essentially it is showing, whether this profile is interpretable, one. Two, does it show severe psychopathology? Does it show a superlative presentation of self, which can either one indicate or give an overall tone towards the interpretation of the further scales into the direction of how this person is actually feeling and how they feel about the different items and different scales on the test, or it can measure a sense of or a presence of very severe psychopathology, or it can render the entire profile meaningless, wherein we have to do the test again. Next come the clinical scales, which as mentioned earlier, there are 10 of them, ranging from 1 to 0. Hypochondriasis, depression, hysteria, psychopathic deviate, the masculinity femininity scale, paranoia, psychasthenia, schizophrenia, hypomania, and social introversion. Now, these further have clinical subscales which were developed by Harris and Lingos. Now, these Harris-Lingos subscales are indicative of why a person, let's say for example, scale number 2 of depression, if a person scores a high score or a very high score on depression, the subscales will be a marker of why a person is scoring very high on the respective clinical scale and should be considered in context of the clinical scale itself and not independently, because they have been developed to better understand what are the core problems that the person is facing in and why such a high score has the person got on a specific scale. Now, then we have the content scales. The content scales focus on the item content of the test, wherein these scales are developed to measure what are the various under various scale headings like anxiety or psychoticism and various other different subscales of depression, to identify items within the MMPI test booklet and see according to which items the response of the person on specific items is how they fare in the overall content and reflections on the responses that they've given on items corresponding to that specific scale. Now, these content scales also have further content component scales which measure specific symptom profiles or specific areas of dysfunction. For example, a scale which measures psychoticism would have a subscales of psychotic, or let's say a scale of bizarre mentation would have a subscale of psychotic symptomology and a subscale of schizotypal characteristics, which would basically identify which area or which symptom profile is the individual leaning more towards. Now, again, as similar to clinical scales, these have to be interpreted within the context of the specific content scales. Now, coming down to supplementary scales, which are broadly again subdivided into 5 different scales. The psychopathology 5, which are the aggressiveness, psychoticism, disconstraint, negative emotionality or neuroticism, and introversion. Then broad personality characteristics of anxiety, repression, ego strength, dominance, social responsibility, generalized emotional distress, which focuses on 3 scales: college maladjustment, the post-traumatic stress disorder scale developed by Keene, and MDS, which is a scale measuring marital distress. Further divided is a heading or a group of scales which measures behavioral discontrol, which includes scales measuring hostility, over-controlled hostility, the McAndrews alcoholism scale, which measures levels of alcohol or addiction or tendency towards substance abuse, and two newer scales that have been developed in the same light, which are the addiction acknowledgement scale and the addiction potential scale, which measure acknowledgement of addiction or substance abuse or alcohol abuse, and the respective maladjustments that come with it. Then the next group of scales is gender role, wherein two scales comprise this group, wherein the gender role of masculinity and the gender role of femininity, which focus on identifying traditional masculine interests and attitudes and traditional feminine interests and attitudes interpreted based on different T-scores. So this gives a short introduction towards the MMPI 2 scales that are there. Now, we will talk a bit about the restructured clinical scales. Now, the clinical scales that we initially talked about have, the good people at the University of Minnesota felt that these need to be restructured, and for good measure. Now, when the MMPI 2 was developed, so the original clinical scales from MMPI were almost directly transferred to the MMPI 2, and for good reasons at the time, because they wanted to maintain continuity from the MMPI and MMPI 2 and make sure there is a certain level of correlation between the two separate instruments. Now, what has been found that there's a need for a more clinical and conceptually informative clarification of these different scales. And besides, one of the major problems in the MMPI2 clinical scales is the high scale intercorrelations, which can dilute the overall interpretation of each and every scale, and low convergent and discriminant validity of these scales. So these scales were later restructured to be made into the RC scales, or the restructured clinical scales, which are again 9 different scales ranging from the RCD, which is the demoralization scale. Now, this is the most important scale in all of the restructured clinical scales, because this sets the overall emotional tone from which measures the level of emotional and psychological distress that the person is facing, and which has to be kept into account when we measure and interpret the various different scales which measure somatic complaints, low positive emotions, levels of cynicism, antisocial behavior, ideas of persecution or paranoid ideation, and dysfunctional negative emotions, aberrant experiences, and hypomanic activation. Now, talking about interpretation. Now, unless otherwise specified, which specifications are there within the manual for interpreting different scales at different T-score levels, we're looking at anywhere above a T-score of 64. 65 and above is a high score, and a score below 40 would comprise a low score. Now, when talking of high scores, now obviously a score of 65 and a score of say 80 on that same scale would have very different interpretative guidelines. Now 80 would be a very high score, wherein let's say on the scale of depression, a score of 65 would describe a certain level of intensity of experienced depression and symptoms, and a scale of 80 would warrant probably a diagnosis of a major depressive disorder or dysthymia. Now, extremely low scores, on the other hand. Now, interpretation of low scores is not generally advised unless mentioned, but an extreme low score given from other further researches that have been done on MMPI2 on various under various contexts. Some of them have been forensic researches, some of them have been inpatient and outpatient clinical researches in addiction centers, de-addiction centers. And low scores also signify a level of psychopathological or personality malfunction. So those are also to be taken into account when we say we're more towards a T-score of 20, 25 to 20 and below would signify an extremely low score and would have interpretative implications which otherwise a low score would not have. Now, after the scoring, the interpretation of all the scores and measuring different areas of personality and psychopathology, the most important thing in interpretation is the context of interpretation. It is extremely important, especially in a clinical setting, to have a mental status examination of the client that you are conducting the test on, and a clinical interview to establish context onto different scales and what exactly are the presenting problems, and see the results of the MMPI in that light and as indicative as opposed to a definitive blanket diagnosis. So this was a brief introduction to MMPI2. There are various resources and it's a very good and very statistically highly researched test. And well, I hope this was informative, and thank you very much.